Hello, in this lecture, we're going to talk, about Parkinson's disease treatment. As in a lot of other neurological conditions, and the Parkinson's disease treatment can be multiple approaches, including non-pharmacological treatment, exercise specifically, pharmacological treatment, and typically commonly used is symptomatic. We now don't have a neuroprotective or disease-modifying treatment for Parkinson's disease yet. Those are active area of research. There's also available surgical treatment for Parkinson's disease, including deep brain stimulation. The effect of exercise in Parkinson's disease has been confirmed in animal models. The MTP animals, usually it's a Parkinson's disease animal models, who are raised in a rich environment with severe toys, and over time lost fewer neurons than those animals raised in empty cages. Exercise reverse motor deficit in chronic Parkinson's disease animals, and also, treadmill can reduce the dopamine loss, decrease tyrosine hydroxylase expression in animal models as well. All those indicating that exercise is helpful for Parkinson's disease. Pharmacological treatment of Parkinson's disease, and so you can imagine that we said Parkinson's disease, the centerpiece of pathology is, you know, substantial nigra dopaminergic neuron loss. That's by decreased amount of cinnamate, decreased amount of Parkinson's dopamine and deficiency. And so the approach you can think about to treat Parkinson's disease, and not a surprise, is to try to increase dopamine release or replace the dopamine in order to restore the dopamine level in the basal ganglia area. Another approach you can think about is just maybe inhibit synaptic dopamine degradation, and or activate the postsynaptic dopamine receptors. And you can do either of them or a combination of multiple approaches in order to treat Parkinson's disease patients. Here shows the common available Parkinson's disease medications, including dopamine precursor and levodopa, and dopamine receptor agonists that include pramipexole, ropenolol, rotigotine, or apomorphine, monoamine oxidase B inhibitors, and including selegiline, razagiline, sulfonamide, catechol O methyltransferase inhibitors, and entacapone, opicapone, the common used one. There are also some medications which are non-dopaminergic, including anticholinergic agents, and or glutamate antagonists such as amantadine. So we will start with the dopamine precursor, the levodopa. And levodopa has been used to replace endogenous dopamine deficiency in order to restore dopamine level in the striatum. And it is the most effective medical treatment for PD. And when it was developed and approved by the FDA in 1967, it rapidly becomes a miracle drug and has improved a lot of patients' quality of life. It's still the drug of choice for PD and the gold standard, and even after 50, 60 years of being available. And it's good and bad. The good is that it's a good medication. The bad part is that we don't have anything else better than levodopa. So the pharmacokinetics of levodopa, including this is the chemical um, name, and it's a large neutral amino acid and absorbed in proximal small intestine and via sheared and L amino acid transporter. And because it's absorbed only in a very small section of the small intestine, and dietary protein may interfere with the absorption of levodopa. The percentage absorbed depends on a number of factors, for example, gastric emptying and the pH level and the peripheral metabolism. Levodopa's plasma peaks within 1 to 2 hours, and its elimination half-life is about 90 minutes. It's an orally active dopamine precursor, and levodopa can cross blood-brain barrier through active transportation. And a lot of people may ask, because we think it's a Parkinson's disease, it's caused by dopamine deficiency, why not we just give the patient dopamine directly? Turns out dopamine does not cross blood-brain barrier, while levodopa can. And upon entering in the brain, levodopa can be converted into dopamine by an enzyme called dopa decarboxylase, located in surviving striatal neurons. And here it shows, if you give dopamine directly, it will not be able to cross the blood-brain barrier. But if you give the patient levodopa, it does cross the blood-brain barrier, and then inside the brain, it can be converted to dopamine. That's the combination of carbidopa levodopa. And here shows how does it work. And without carbidopa, the levodopa will be just converted to dopamine in the peripheral system, and will not be able to reach to the brain. And with carbidopa inhibiting the decarboxylase, and levodopa can, more levodopa can reach to the brain, be converted to dopamine. Typically, carbidopa levodopa can be used to started with the half type of the 25 100 milligram type every 1 to 2 weeks. The dose can be increased by 1/2 tablet up to 1 full tablet 3 times a day. The duration of the action of this carbidopa levodopa is typically about 4 or 5 hours, so it has to be administered 3 to 4 times a day. So if disabling symptoms persist, the dosage can be gradually increased, but older adults rarely tolerate total levodopa doses more than 1,000 milligrams a day. The common side effects of levodopa includes GI discomfort, nausea, vomiting, diarrhea are common, and if you started patient with a high dose of levodopa. Cardiovascular side effects including orthostatic hypotension, lightheadedness, fatigue, and syncope in extreme case. Central nervous system side effects including drowsiness, confusion, and sometimes visual hallucination if the patient is taking a higher dose of levodopa. A typical patient with Parkinson's disease being treated with levodopa can live a good, maybe 5-10 years, and with good response to levodopa and with good function. That's the so-called levodopa honeymoon period time. But up to 50% of patients after 5 years of treatment, and 70% of patients after 15 years of treatment with the levodopa, they will eventually develop motor fluctuation. This fluctuation as a complication of levodopa treatment is believed to be related to levodopa plasma concentration fluctuation. And it's dose related. Higher dose of levodopa can increase the risk of the risk of motor fluctuation and complications. It occurs more frequently in younger Parkinson's patients. The common levodopa-induced motor complications include dyskinesia, which is an involuntary rhythmic movement of the face, arms, and legs, or trunk. We use dyskinesia here, but actually dyskinesia is a type of chorea. So from phenomenology standpoint, it's chorea, but induced by excessive amount of dopamine. Another type of motor complication is the so-called diminished response to levodopa. And in those cases, drugs becomes less effective with prolonged treatment. And also, patient can fluctuate a lot in response to levodopa, including end-of-dose akinesia, drugs effectively wearing off prior to the next dose, or the so-called on-off phenomenon, which means the drug effectiveness decreases suddenly, followed by spontaneous remission of symptoms. All right, we just talk a lot about levodopa as a dopamine precursor. There are other approaches to treating Parkinson's disease, including activate postsynaptic dopamine receptors. Commonly used dopamine agonists, including ropenolol, pramipexole, and rotigotine transdermal patch. Remember, dopamine is released to the synapse and work on the postsynaptic dopamine receptor. Here, if you use a dopamine agonist, it can carry on the similar function of dopamine, but without requiring dopamine in the system. It can be used by itself or in conjunction with the levodopa. May be particularly useful for younger patients with Parkinson's disease, especially those with milder disease. And the effectiveness is less than levodopa, but earlier use can oftentimes delay the levodopa-induced dyskinesia. It requires slow titration, because nausea, sleepiness, orthostatic hypotension, and hallucination are common side effects for dopamine agonists as well. There's also real but serious side effects can be caused by dopamine agonists, including sudden sleep attacks. Patient can fall asleep during driving or while walking. Some other adverse events would include compulsive behavior, such as pathologic gambling. May be much more common in patients taking dopamine agonists. The common used dopamine agonists including pramipexole, which is a high D2-like receptor binding medication, and usually started with 0.1 to 5 milligram 3 times a day, and then the maximum dose is 4.5 milligram a day. It excreted renally, so used with caution in patients with renal disease. Ropenolol is with high D2-like receptor affiliation and affinity, and usually started with 0.25 milligram 3 times a day, and the maximum dose can be 24 milligram a day. It metabolizes through CYP 45018-2, so the clearance can be reduced by cipro and estrogen. Some other dopamine agonists here, and rotigotine is a transdermal patch. It works on D3, D2, D1 receptor, and the dose range can be 1 to 8 milligram every 24 hours. It's excreted by kidney. Apomorphine is a broad spectrum D1 and D2-like receptors agonist. It can be used as a rescue therapy for patients with severe off state when they have Parkinson's disease for a longer time. The formulations include a subcutaneous injection, and also recently has been available as a sublingual film. You can put a film underneath the patient's tongue. It gets absorbed very quick, and then to carry on the function of dopamine agonist to rescue the patient from off state. The common side effects are nausea. Um, we talked about earlier, and another approach is to inhibit synaptic dopamine deregulation by different way. And we know that the primary mechanism of dopaminergic removal from the synaptic cleft, including when the dopamine is released to the synapse, it can be reuptake by presynaptic dopamine transporter, but also it can be metabolized by monoamine oxidase B, also catechol or methyltransferase CMT. Those two enzymes work as to remove the dopamine from the synapse, so it would not constantly carry on its function, give the synapse, the postsynaptic neuron a break. Think about a way if we have medications either inhibit the MLB enzyme or inhibit the CMT enzyme, we can potentially prevent the metabolism of removal of dopamine in the synapse. By doing that, you can increase the level of dopamine in synapse and also maybe keep them there for a longer time to carry on its function, especially in the setting of dopamine deficiency. MLB inhibitors, the commonly used one, resagilin, selegiline, and they, a little bit about the neurotransmitter. MLB isoform, there's two isoform, MLA and break down serotonin and norepinephrine and the dopamine, but MLB is specifically breaking down dopamine. So the mechanism of action for MLB enzyme inhibitor is to prolong the effects of dopamine, synapse. It can be used alone or combined with levodopa, may be particularly useful for younger Parkinson's patients with milder disease. And it's less effective than levodopa, but early use can delay levodopa-induced dyskinesia similar to dopamine agonist. It's generally well-tolerated and do not require diet restriction. And as we said earlier, selegiline and resagilin are the two medications available. And resagilin specifically is a selective irreversible inhibitor. It carries a 0.5 and 1 milligram tablet, and it can be used as adjunctive treatment or monotherapy. Its modest effects on decreased off time and increased on time, and there's also believed to be a possible neuroprotective effect, but it never been confirmed in large clinical trial. It's contraindicated when patient with taking ephedrine or if somebody has hypertensive crisis. So CMT inhibitors increase the duration of action of levodopa, resulting in greater on time for a given dose of levodopa, but it can also exacerbate the dyskinesia. Adverse events of CMT inhibitors are similar to those of levodopa, including dyskinesia, nausea, diarrhea, constipation, discolored urine. And tolcapone was the first drug available for use in U.S., but was later on withdrawn from the market because of significant liver toxicity. Now the common used entacapone is a 20 milligram tablet, and it has to be administered with each single dose of levodopa. Apicapone is a newly available CMT inhibitors and approved a couple of years ago by FDA. It can be used 25 to 50 milligrams once a day. So that's the advantage of apicapone. It doesn't have to be with each single dose of levodopa because it's a longer acting inhibitor. Other non-dopaminergic medications for Parkinson's disease, including amantadine, it's traditionally an antiviral agent. The mechanism of action is not very clear, but it's believed that it can block AMDA receptor, can increase dopamine release and decrease dopamine reuptake. Usually it's given along with levodopa and can provide mild improvement in Parkinson's motor symptoms and decreased dyskinesia. The common side effects of amantadine includes orthostatic hypotension and confusion and skin discoloration. And this is a picture considered it's with the skin discoloration and the so-called livedo radicularis. This is a very specific adverse event from amantadine. Usually patient doesn't feel any discomfort, but it's hard to watch. Older adults, especially those with impaired renal function, can develop confusion and hallucination while taking amantadine, something to be careful. Anticholinergic medication traditionally has been used for treating Parkinson's disease, including benztropine, trihexyphenidyl, and the mechanism of action including muscarinic receptor antagonist, and it's believed that it can help restore balance of dopamine and acetylcholine. It can moderately improve some breathing symptoms, including, specifically the tremor. The adverse events such as dry mouth, urinary retention, and confusion typically outweigh benefit in most older adults. So if you have younger patients with tremor-dominant Parkinson's disease, you may be able to get around with anticholinergic medication. But if you have an older patient, particularly those older than 70 years old, you better not try to put the patient on anticholinergic treatment because of the significant, higher frequency of side effects. We talked a little bit about earlier, and there is a surgical approach for treating Parkinson's disease, the so-called deep brain stimulation. DBS uses an implanted electrode to deliver electrical stimulation to structures involved in the control of movement in order to bring motor controlling circuit into a more normal order, thereby reduce movement disorder symptoms. There are two targets being tried, including subthalamic nucleus or globus pallidus internus. And either target being used to treat Parkinson's disease to place the electrode in that spot. And it does significantly increase on time and decrease trouble in dyskinesia and motor fluctuation. And the best predictor for a good response with DBS is those patients have good response to cinnamate, to levodopa. So it's not a surprise, and you are looking into those patients have good response to levodopa, but develop tolerance and or side effects that they need something else in order to carry on the benefit. There's typically no age cutoff, but typically, if a patient is older than 80 years old, the surgeon has a tendency to not perform DBS for those patients unless the patient is otherwise healthy. Complications of DBS include surgical site infection and intracranial bleeding, and a cognitive and speech problem are quite common as well. And also sometimes some patients develop gait abnormality after DBS placement, increase the risk of falls. Okay, and this is just a quick overview of Parkinson's disease, pharmacological and the non-pharmacological treatment. And if you have any question, and feel free email me and the program. Thank you again.